Scott County, providing safe, healthy, and livable communities.
County Delivers, and Chris Harder will get us started. Welcome. Thank you.
Good morning, Madam Chair, Commissioners. This morning, we have a large group of folks that are going to be talking with us about the Birth to Five program. That's a collaboration between Public Health and Children's Services Child Protection. It reflects the county's efforts to achieve our bigger goals related to safe and healthy communities. And it's really especially interesting, I think, because this project came out of a previous Scott County Delivers and some work that teams did in collaborating to prepare for that. And Suzanne and her team are going to talk more about that. But it's really kind of an effort of our best hope is that people come together and create something new and better. And so they're going to talk about that in a little bit. It also represents really a strong collaboration between county partners and community partners, and many of them are here today. This is an especially nice group, a large group of folks from across our community, and they're going to introduce themselves in a few minutes. I also just want to recognize we have a number of the Birth to Five staff that are here, and those are the people that are really doing the hard work directly with families, so I want to note that their presence is here as well. And so really we want to thank especially our community partners. There are people that came. Sally Stockey isn't even back at school yet, and she's here on her day off. But we just really want to thank you for the time that you've put in to be here today and to help us prepare, and when it was applicable to share some of your data with us as we talk with the commissioners this morning. So with that, I think we'll ask the panel members to introduce yourselves. We'll ask all of you to introduce who you are. And then I think Suzanne is going to do a quick overview. Yes?
Yes.
Okay. Thank you.
Troy Pint with Enterprise Business Technology.
I'm Lori Huss with Employee Relations.
Jennifer Schultz, Office of Management and Budget.
Nancy Martin, the Director of Family and Children's Services for the Shakopee, Mdewakanton Sioux community.
Good morning. My name is Alyssa Nesvold. I'm a care coordinator for Park Nicollet, and I work in the OB clinic in Shakopee.
Sally Stockey, I'm a school social worker at Central Family Center, which is the district's early child programming.
Melissa Gardner, I'm the crisis nursery manager for the CAP agency.
My name's Peter Goldstein. I work as one of the housing coordinators with Scott County.
I'm Mary Kay Stevens with Scott County Public Health Supervisor in the Family Health area.
I'm Julie Swanson. I'm one of the Child Protection Supervisors.
Hi, good morning. Suzanne Arnson, Child Welfare Manager. I just want to make a note. We have, again, more representatives of our Birth to Five multidisciplinary team that are with us today, so I just want to acknowledge that they are here to help contribute to the conversation.
Thanks, Suzanne. You want to go ahead?
Sure. So, as Chris already mentioned, she took some of my thunder in terms of really identifying that we are here as a result of a conversation that happened through Scott County Delivers in November of 17 when Children's Services and Public Health presented around early intervention and prevention services. And from that, a next step that was identified to really try to look at how do we move interventions more upstream, how do we look at more proactive approach. So a strategy that was identified was the development of an infant. At that point, we were returning an infant multidisciplinary team. So fast forward 2 years later, we are here as a Birth to Five multidisciplinary team. And so that, I think, is really just the reflection of how we took a continuous quality improvement strategy and began to really implement that across our system. The goal of that work was really to take a look at how our data contributes to program changes. And so many of you have heard me talk about within child protection, we are seeing increasing numbers of children entering placement. As we dug into that, sort of the next layer, we looked at children 0 to 5. We were seeing them overrepresented in our placement data. As we dug into that further, we see it's children 0 to 5 with parental substance challenges. So we took that as an opportunity, one, to restructure child protection. So we created 4 specific positions that would work with this population of families, and we really formed about a year ago this Birth to Five multidisciplinary team with key messages around how we move interventions upstream in a more preventative way, how we integrate services better and differently for families, and really how we are understanding key roles and responsibilities across the different agencies that are represented, and how that will help support more seamless services for families. So that's just a little context, and I'll turn it back over to the panel.
Great, thank you.
So I'm going to start with the last measure on page 25. So I see this is kind of a parent support group, and I'm assuming this can be kind of go hand in hand with county staff contacts and whatnot. And I'm very happy to see that it jumped almost or over double from 17 to 18. So what factors led to that big jump of utilizing this group?
I can speak to that. So I manage the Parents Helping Parents for Scott and Carver counties, and in 2018 we were able to grow to add an additional group to our program, which serves families in the evening. That particular group is in Carver County, but we do open all of our groups to all of our families. So families from Scott County additionally attend the Carver County group as well. And so that evening group really opened up the opportunity to families that are working during the day, and so we saw an increase there. But I also think that due in part to the work that we're doing in the multidisciplinary team and spreading the word about the program and working closely with the school district to get referrals for families that are high risk into the program. Our Scott County group in particular saw a lot of growth last year, including a lot of participations from fathers. So the group has been very successful, and we're hoping to continue to grow that.
Thank you.
And can I just sort of add on to that, and Melissa, you can help me. So Parents Helping Parents is sort of under the umbrella of the Circle of Parents.
It's a national model, yes. Circle
So-
of Parents is a national child abuse prevention parent support group, yes.
So, and I think that's important. It is likely part of the evidence-based service provision that may in fact be approved federally. It has not yet, but it is part of a potential service that would be an evidence-based program that, as we think about federal legislation that would provide matching dollars for specific services, this may be one of those.
So is the enrollment voluntary, or is it families that meet criteria, both, or?
It is voluntary. We try to target high-risk families in our community, or families that maybe don't fit the traditional ECFE model or early childhood family model, might have more struggles at home with their children, things of that nature. So we do go based on referrals, but we also put information out there through the CAP agency, through our community ed brochures and things like that to make families aware of the resource.
And with that group, have you done anything with like participant satisfaction or surveying those parents?
Yes, annually we take a satisfaction survey, and we also focus highly on parent leadership, and so we're kind of getting the feedback from the parents as to what they need, and then also really trying to elevate them as leaders. And each year we honor an unsung hero within that group, and it was a parent who renamed the group from Circle of Parents to Parents Helping Parents.
So I have a question related to page 12, or at least it came from page 12. And my question is, how has this special programming impacted families? What are the initial things that are exciting this group about how this focus is improving your outputs or outcomes?
So I think one, just from a process standpoint, we're not here necessarily with outcome data specific. Yep. Because it really is around how we used data to create the special programming.
Okay.
But I think it's an opportunity to talk about even, I guess I'm going to look to the team, like the case consultations, and for folks to talk about how that perhaps that interdisciplinary process has supported the work for families. So I'm going to look down at some of my colleagues down there.
So I did have the opportunity to do a case consultation with the multidisciplinary team and was given the opportunity to discuss a case that was particularly challenging for me and my work in healthcare, which I found extremely valuable, because even though my work is focused in healthcare, I can't do my job without everyone at this table here. And to better be able to know who is doing what and how the services are provided, and also tap into individuals' areas of expertise, is invaluable. The information that I got from the consultation that I did allowed me to better serve the patients that I work with in a variety of different situations, not only the patient that I consulted about, but use that knowledge going forward for other interactions that I have.
Alyssa, can you say anything about, because obviously we're talking about babies and parents with substance abuse. That is a high risk, highly vulnerable kids. Like, how did that collaboration contribute to safety in your experience with that, the information you got from that team?
So I work with moms who have a history or currently are using substances during their pregnancy. And so the knowledge that I have that I can share with patients earlier gets that intervention to families earlier in the process to hopefully reduce some of the harms later on. So just being able to expand my knowledge base in terms of referrals and resources, which has expanded. I don't have a number for that specifically, but just the quality of my work has improved as a result of being on this team.
Thank you.
So this is more of a logistics kind of process because this is new to me, but how are you guys able to share your data or do this consultation? Have you been able to do data sharing? Are you doing it in kind of general terms when you're doing case consultation, or how does that piece work?
I can maybe speak to that. So I'm with social services for the tribe, so when we got together for one of our meetings, we staffed one of my cases. Of course, no names are used, but just the scenario. And I was also going to add the piece that you were talking about, you know, being able to share resources. I have a really small department of 5 staff, but joining with so many different providers to be able to talk about very difficult situations and to get the help that we've gotten just by being a part of this process is invaluable. I mean, just speaking to the case that we staffed, mom is expecting, and just the issue with the drug use and being able to kind of talk that through and figure out what we need to do, what resources are available. It's really been, you know, really helpful.
So just in general, somebody maybe talk a little bit about that data sharing piece and what we're doing in that area, because it seems like maybe that's one of the barriers we deal with, because I would think some of these families cross over lots of the different disciplines.
So there is a Minnesota statute that governs the ability for child protection to come together for case consultations. So there is some statutory provision that supports this work. And I think we would all acknowledge that even despite the statutory provision, different organizations have different legal interpretations or willingness or ability to share information despite that. And so I think this group would acknowledge data privacy, even in a case consultation framework, still can be challenging. The statute provides the ability to share names, to share, so that, right, we could potentially be looking at how do we reduce duplication, but different organizations have different legal directions. And so that can be a barrier in terms of different agencies that cannot share client names. We just then talk about sort of scenarios and how we might approach that. So again, there's statute that provides, but data sharing is just always a challenge.
Well, that being said, with the way that we walk through the case consultation process, I mean, we are able to, I don't think it stands in the way of us being able to think our way into and through the case. We can talk about mom, dad, 5-year-old, infant, and really work through the case still in that way, in a meaningful way.
And from a housing perspective, you know, one of the primary concerns that we have with the households that are going through this group are the rental barriers that they're presenting with. And so offering opportunities for the staff that are working directly with the households to assess those barriers, identify them within their own already established constraints, and then be able to offer suggestions based upon what they're coming back with has been an opportunity to skirt some of that.
And with housing is a good example of, separate from case-specific information, like housing right continues to come up as a barrier. And so initially when we started, we didn't have a housing representative as part of the group, but as we continued to hear case consultation and from partners identifying that, we were able to invite Peter to then be a part of our team, so he can be a part of those case consultations.
Peter, can I clarify? So are you able to leverage the fact that a family is working with a social worker or with this program around some of those housing barriers? Like, because I was reading on page 3, some of the data that that you cited around the family unification vouchers.
Certainly.
And some of the barriers people have, even if they have a voucher, to finding housing. So does a families work with a team like this, something you can leverage with a landlord, or how does that work?
It can be indirectly. So the value of collaboration allows for us to identify where the households are really struggling to get into housing. And as a result of that, we were able to bring that back into our planning. And locally or regionally, we have a program called Beyond Backgrounds. And without going down too far of a dark hole, we were able to expand eligibility for that program to serve those that are recipients of the Family Unification Program voucher. And as an extension of that, we are able to offer a landlord risk mitigation fund to those that are presenting with pretty significant rental barriers.
Okay, thank you.
Can we go to page 13, please? And my question here is just around the data. What have you guys just decided, or what do you know about why Scott County might be higher or showing higher in this data set?
Well, I think certainly statewide, nationally, opioid parental substance is just a driver. I don't know that I have good reasons as to why we are higher compared to like metro or state, but certainly increasing number of young families. And so as we see, it's just the increasing trend overall of placements, and then certainly children related to parental substance challenges is sort of driving some of our placement data, not in its entirety.
So outside of housing, what other challenges has the Birth to 5 team kind of identified so far? I know it's very early yet, you've only been together since January, but anything else rising to the top outside of housing?
One of the things that people are talking about a lot is the access to chemical dependency treatment. Oftentimes it's challenging to get parents on board and ready to take that scary step. And then we get them there and there's not a bed available. And so there's just a lot of work that staff have to put into trying to find the resources and keep the clients ready and able to go.
You know, I have a question that, Mary Kay, I'm hoping you can speak to. On page 2, there's some data cited from the Community Health Survey. And I'm wondering if you have any trend data on the rates of prenatal exposure. Like it says, I think, 30.8 per 10,000 live births in Scott County. And do we know anything about the trend in that area?
I think this is specific to the neonatal abstinence
Yep.
syndrome. So I think as the state is tracking that, or as it's become more and more prevalent, that'll continue to go. I don't have the data at hand as far as, but I think what we're seeing is more and more families are coming to us, and that's part of the issue is substance use. This is one piece of that. So I would suspect that over time we're seeing an increase or better identification or those kind of things. So I know that in some circles, it's really considered a crisis around some of the opioid use and things in the state, and particularly in populations of disparity. And so that tells me it's kind of everywhere. We're all concerned about what are we going to do to protect these babies and help these families.
And are your staff involved in any of the direct medical care for infants, like as infants are detoxing, or like are they involved in that care, or are they primarily involved in that care with families after babies are home and well?
Yeah. Ideally, we're involved or able to support a family during the pregnancy, and that's been a part of our B25 work and discussions too, internally and with the large group, is how do we find those opportunities and do things differently to have earlier opportunities to intervene and offer support. So we often will get connected with them, not as much in a medical role, but we make sure they're connected to those medical model providers, and that all these folks and wherever a family might need additional supports to continue to go on a healthy path, get in further prenatal care, get connected to therapies they might need or treatment, those kind of things, or respite supports, housing, all those things that support their recovery. And as the same after, we our primary role would really be in coordinating and advocating for them around some of those medical or health needs and making sure that they're able to navigate that and help break down the barriers.
Okay.
Because they're going to live with us a long time beyond when we're involved, and
Yeah.
so we want to help them get connected to those systems.
Sure.
And there's been huge benefits, just if I can add, by, in our B25 consultations, having some of those partners around the table where we can say, here's something that's coming up for us. We're seeing symptoms in mom with her recovery medications, and we're wondering, who do we go to kind of coordinate, who's managing that, what should we expect, what are the resources out there to help wrap around them and get them.
Nice.
I think some additional sort of pieces, as Mary Kay talked about, like, again, how do we focus on moving those interventions further upstream? And so as Children's Services and Public Health talk about working together, we've been able to engage the county attorney's office on really looking at, for example, child welfare as a mandated response for parents, for moms who are using during pregnancy. But there was a data issue, a data exchange issue on can we, when we, child welfare, get the report, engage with public health on those referrals. So we've created a standard operating procedure that enables that on any referral. We're able to immediately then engage public health to create joint responses. So we see that it enables a medical, but a different sort of lens as we talk about outreaching to high-risk moms. The other piece that we are really excited about, it is not finalized, but is when we have child protection reports that are screened out. So a call comes into the county with a concern about a child, 0 to 5, but it does not meet child protection criteria, so it gets screened out. We are statutorily responsible when we screen to have a multidisciplinary team. So we have public health a part of that. We might have law enforcement, county attorney's office. But if public health was in the room, we still couldn't give them the information. Like, they could see we have a pregnant mom, but they can't do anything with the information because of data privacy. So again, we've drafted a standard operating procedure that we're working with the county attorney so that screened out reports can in fact move to public health as an outreach of service to try to prevent that family from coming into child protection.
We look at page 14. And I'm just noticing the big change in the adoption data and wondering what it's saying and what you're seeing in that, or what might be trending, if anything.
You want me to speak to it?
Sure.
So I think as we talk about, and as we looked at, this is some of the data, right, that has prompted this work.
Yeah.
Because we were seeing increasing number of kids entering, and we saw increasing number of kids who are going to permanency away from their parents. And so that is why we're sort of here today, is can we interrupt that pattern? Parental substance is a complicating issue. And so when we talk about substance treatment and then sobriety, oftentimes we have to build in relapse being a part of that. And so we are met with child protection timelines around 12 months of placement, and recovery, addiction and recovery, which has relapse a part of that. And so we are trying to figure out, we bump up with permanency timelines and then relapse and recovery for parents. So we might get parents sober sometime during that 12 months, and then they might relapse towards the end. And then we have to make decisions around how to secure ongoing safety. And for the life of an infant, 12 months is a long time. And so, again, I don't know that we have the solutions, but we are hopeful that this group helps figure out, are there different opportunities to change that trajectory? Because we know we're talking about young kids, highly vulnerable, but also really young parents. And so how do we align sort of treatment and recovery in a different way?
A case example, one of the cases that was brought forward for consultation was specifically a case where the challenges that this family was facing were such that, from our experience in working with families, you could just see the writing on the wall was that this is going to end up in a termination of parental rights. And so really that was the purpose of coming forward to the consultation, is to say, like, how do we look at this differently? How do we intervene differently? How would we give this family their best opportunity towards reunification. And it was an exciting consultation in that there were a lot of ideas, there was a lot of information that was shared in a way to look at the situation differently than how it might just sort of go down the track towards a termination of parental rights and adoption. And it wasn't just bringing forward the ideas, people were sitting down together and figuring out who could do what tasks, so it wasn't all just this laundry list of things that a worker had to do on top of the work that they're burdened with. So it was a really nice example of trying to make a difference on that data.
From the school's point of view, I just think of an example like that. A family might be referred to the Help Me Grow, and a birth to 3 team could do an evaluation and possible home visits. But in early childhood, all the programming is voluntary. So it's tough to get a parent invested and involved when they're kind of taking a risk of someone coming in their home. I think my goal with early childhood is we do collaborate Parents Helping Parents programs in our school. We have Head Start to build a community where families feel comfortable and supported no matter what their situation in the school district. Because even later, if they can have a good experience in early childhood, which is voluntary, all kids go to school. And if they know that there are support systems, school social workers that are there, I think there's a better chance of kids doing well. So building a positive environment for the schools, because they're less likely to let us know what's going on, but there are true signs that we can see.
I have some questions on, actually around the crisis nursery, so those are slides 22, 23, I think, and 24. That gives us information on really kind of the calls and the amount of services rising. Do you have data around, is that related to substance abuse primarily, or are there, again, kind of getting at the other contributing factors to kind of those increased calls and services needed?
Yes, that's a great question. Unfortunately, due to the fact that Crisis Nursery is a voluntary program, oftentimes it's difficult for us to identify substance use as a barrier. When a call comes in, we do kind of a risk factor screening. We don't come right out and ask the family, what their risk factors are. We just kind of discern from our communication with the family. And then from there, we go out to the home and we meet with the family, and the children are present and try to get a bigger picture of kind of what's going on in the home. So I don't have data at this time to show where substance use is particularly on that spectrum, but it's a challenging one because it's less easy to see than a lot of the risk factors, being single parents or young families or things of that nature that are just apparent. So that's one of the things that we've struggled with as far as identifying cases to consult, because we may not know coming into it that a family is struggling with substance use. But that's definitely something that we're looking to screen better for going forward and look kind of deeper into kind of how we can get those questions answered in an honest way.
Can I ask a couple questions from page 6? Under next steps, I actually had 2 sets of questions. One is around the future data plan. So you had laid out, these are some pieces that we would be tracking going forward. You spoke to this being a new program, not a lot of outcome data yet, but also laid out what I thought were some nice data points to monitor going forward. So I'm wondering a couple things. What do you need to do that, like to collect that data? And then are there pieces of those markers that you think are going to be most important to watch?
Well, in terms of what we need, like my pie in the sky is, how do we create an integrated data system, right? And because what we end up having is each area potentially hand counting or hand tracking different pieces of information. And I think all of us at this table are really sensitive around frontline staff needing to hand count or direct or somehow collect additional information. So integrated data. Short of that, I think we certainly have talked about how do we evaluate the effectiveness, so to speak, from this group by a survey response. And that can happen, I think, pretty naturally through a survey tool through the county. In terms of other key data points that the team is interested in, you want to speak to that maybe, Mary Kay?
I can say a little bit. I know on my wish list is that ideally we would be connecting with families before they got to child protection and helping get them connected, so we can help prevent some of those things further down the road. We have had discussion as a B25 group aside from the consultation about what are the things that we would see as successes and what are the things that we know we were making a difference. Things like families are connected and able to access the things that they need to continue on a positive trajectory and things like that. And so I think we're just at the point of figuring out which hard concrete factors, now that we've come together, built the relationships, we've kind of created a system for doing this. It's what can we really measure with hopefully some integrated data, some hard numbers to really show. So.
Okay, so your hope would be that we would have some of that going forward?
Absolutely.
Nice.
Yeah, more focused. I think
Okay.
we have an idea, it's just which concrete measures.
You want to pick and commit to? Okay.
And what's feasible and reasonable to track. And we've had a lot of discussion about how we build it into what we're doing already without burdening the workers and, not hand counting out of our databases and things like that, so.
Okay, thank you.
Can I add, Lisa Brodsky from Public Health. I'm very pleased to share that PHDoc is now downloaded, and we are currently training our staff with that. This will hopefully enable us to do some data sharing as well, utilizing the Dakota County system. They've created a B2 8 data sharing system and portal that they will be rolling out. They're testing right now, will be rolling out at the end of the year. This will have implications for other programs as well that we work with, like in early childhood, but this could be a possible way that we could at least identify some markers at birth and be able to share that data, or have at least a portal that we can share limited data.
Thanks, Lisa.
Also on page 6, one of the things that kind of caught my eye that I would like to hear a little bit more about is, I think it's like bullet point 2, where it talks about two-generation grant application. So just first question around, can tell me more about that. And the second question, the reason that piqued my interest is I just wonder how this team deals with the challenges of multi-generation families with substance use and issues of homelessness and other barriers. How do you guys deal with that? How does that impact? And it seems like that would be very difficult.
So your first question, and unfortunately, thanks for bringing up our bad news. So yesterday we were notified that we did not get the grant. So
I didn't know that. I didn't.
So we are disappointed certainly that isn't coming our way. I don't think it is disappointing, and I think it is work that will continue, and we will continue to look at what are the other funding sources that might support the work. I think certainly from a two-generation, multi-generational approach, that is certainly the work of Birth to 5. It spins off with the Committee to End Child Abuse and Neglect. That really we can't focus interventions at a child level. It has to be how are we sort of serving whole families. We recognize, right, children don't exist in vacuums. They are part of a family system and often extended family system. And so how do we look at interventions that serve both? Because that really is what is going to have and produce the best outcomes for kids. So it's part of what we did at our last community advisory meeting is looking at what are services and supports that support kids only, what supports parents, and what supports that multi-generation approach. And so as we continue to map that out, then we can better identify where gaps are and what do we need to build.
And while we weren't awarded the two-generational grant that you guys applied for, one of the key components of our primary prevention resource, the Family Homeless Prevention Assistance Program, has recently transitioned into a new biennium. And from that new biennium, we've shifted around our programming to be increasingly more two-generationally focused. And so hopefully some of the resources that we were hopeful to employ with this group I'll be able to bring back as one of the grantees for our FHPAP program.
I just want to add, I think all of us, many discussions going on about being trauma-informed And a lot of the stressors that families have can come from a history of trauma that they've had. And so we think about not what's wrong with them, but what happened to them. And so we need to address how parents are doing and supporting parents in healing so that they're in a good place to be parents to their young children, that their relationship develops so that kids have that healthy, stable, secure base and relationships with caring adults to move forward in a positive way. So I think that's a part of a lot of our work, certainly is in home visiting, foundational to addressing both generations taking small steps to heal.
So recognizing sort of that idea of how does historical trauma, both within a family or culture, how does that impact current day functioning? We know from an individual level, trauma impacts brain development. And so how do we just continue to think about how interventions then need to be tailored based on a parent perhaps who has experienced trauma in their own life? And so that's I think exciting work to do, but it's long-term work to do.
Can you talk a little bit about, on the first page you talked about workloads often impacted a worker's ability to consistently meet with parents. And I'm believing that maybe this new team has formed to enable more time and focus on these 0 to 5 families. Can you talk a little bit about some of the changes you've made based on the data you've seen to try to impact?
Well, for child protection, one of the main changes that we made was when we went through the restructure and really carving out those 4 specialized positions that are focused on those particular families in case management, and they're separated out from doing other work tasks such as the assessments that can interrupt the intensity of the work that these families need. So it's carving out that time. It's also finding like training opportunities for them so that they're more and more specialized in the safety planning and assessing the risk and like the quality and effectiveness of the work that they're doing with the families.
Okay.
As we looked at the restructure within child protection, really there was conversations with staff, and what we heard from staff who held both responsibility for case management and assessment was case management families sort of suffered because they would have to cancel appointments in order to be able to respond to assessments, because assessments have rapid timeframes that we have to get out and see kids. And so by carving these 4 positions out, it like Julie said, it minimized that interruption so that there are less agency needs to cancel, so you have more continuity in that care for families.
Is the B25 then approach, are our services being delivered to families collaboratively, or is it more the planning for the services that's being done collaboratively? Can you talk about that a little bit?
Well, can you ask that question again? Like, I'm trying to understand what you're specifically wondering about.
So do you go out together across the multiple disciplines to service the families, or are we just planning for the service with the families collaboratively?
There are joint home visits often between child protection, public health nursing. There was a case that we worked closely with Crisis Nursery where we were trying to do a family arrangement and avoiding a placement for a family around a mother who's a primary caregiver. And at a certain point, the needs for the safety planning were too great, and so we were able to partner with Crisis Nursery and do a voluntary placement agreement and stay out of court for a short period of time while we like regrouped and built the safety network, and we used the crisis home, so it was a familiar connection, so there was that sort of partnering as well.
And I think anytime the county receives like reports involving our tribal partners or tribal members, so we do those assessments. We are mandated, and certainly best practices, we do those in concert with our tribal colleagues. Nancy, if you want to talk about a little bit about your, like you have your own child welfare service.
Right, we are self-contained. We're a small department, but we serve the tribe in the tribal community. We have tribal court that we are using. So, but when we get reports, a lot of times we'll get a cross report. And so it really works well. We'll go out together and we'll staff that, we'll team it. We've had really good outcomes doing it that way. So, you know, we hope to continue to do that. With that, there's always the resources and referrals to other, like Crisis Nursery or, you know, the health department. There's just all those opportunities when we are working in conjunction with Scott County.
I've done some collaborating with Melissa with families that are in early childhood programming to join the Parents Helping Parents. But I also brought in a couple years ago the Scott County Mental Health School Program that is now serving the early childhood program. And so we built a full caseload there, so there's definitely some collaboration.
Even the preparation though and the consultation piece, I'm rarely able to meet with these folks at the same time as I'm meeting with the patient. My work is all in the clinic. I'm not able to do the home visits and the home work that many others are. Being able to have that coordination piece has been extremely helpful. And so even when they're not there physically, it's still immensely beneficial to say, I spoke with Melissa or I spoke with Mary Kay about X, Y, and Z, and just to be able to do a better handoff has been huge.
I agree, having names and contacts as opposed to programs has been essential for families to follow through.
One of the things I've also really appreciated, and I think our last consult was a great example of our team working together on the back end. And so, you know, a case was brought forward and the worker, you know, kind of walks away with a list of things to do, but there were several people in the room that said, I can do this, or I'll help with that. And so it might not be physically at that visit with you, but when someone else, Peter in particular in this case, was doing a housing assessment for that family, it gets the ball rolling a lot quicker, and it takes a little of the burden off of the worker, and these cases tend to be very taxing and difficult, and so when you have that team approach and people behind you willing to put in the work, it really makes it a lot easier for us.
Great. I feel like the more we're talking about it and getting to know each other, the more we are learning about how each other's services work and opportunities come forth about how we can do better for families. That's been really exciting.
Can we talk about the data on page 15 for a minute? So I wonder if you can just help us. What seemed clear to me in the data is that there's an increased number of kids going into placement, and we have worries about that. There's a slide on page 17 that shows that overall Scott County has a really low rate of out-of-home placement. So although it's going up, we continue to have a low rate of placement. But then we have these kids who are the subject of more than one child protection report in a year. And so I wonder if you could just sort of talk us through what are the important points of that data for you.
Sure. So one, to just know, this data in itself is not specific to kids 0 to 5. So this is kids 0 to 17 that are reflected, but certainly we see it as an indicator to think about. So for last year, we had 20% of our kids who were named as victims. And I think that's an important distinction. It is not all household kids. If we look at kids that are part of an assessment, we might have a family of 4, one child is an alleged victim, but we are really planning with all 4 children. But we have 765 kids who were victims, and they are then named again in a child protection report within 12 months. It does not mean that it may not mean that kids are experiencing 2 episodes of harm. And when we talk about that is, so we might have a physical abuse case in January of this year, and Johnny sustained a bruise. So that's a substantiated maltreatment. And then if that comes back again in August of this year for physical abuse with a bruise, so those are 2 episodes where the child was clearly harmed. That isn't what this is telling us. This first on slide 15 is really around just looking at kids who are named in reports 2 times within 12 months. If we move on to slide 16, what we did to try to better understand that, because we certainly see our performance somewhat changing, like our performance has started to increase in 2013. And so to try to dig under that. And first of all, I can say this is really complicated, difficult data to dig into, and it has really required a partnership with the Department of Human Services. And so they have been strong partners to help do some of the data pulling for us, because otherwise it really is hand counting. But what we look at, when we try to look at, are the kids that we are responding to experiencing harm 2 times within a year, meaning a child is injured, or that there is a need for child protective services twice within a year. That's what slide 16 is saying. That's a smaller percentage of those kids. And so, again, we're wanting to make sure that when we touch a family, ideally we don't ever touch or see them again, that we've secured safety and supports for them, and that they are able to move forward without us.
Okay,
Does that help, Chris?
a little bit.
Can I ask quick, was that for kids under 5, that total, so 2018, 765?
No, this is for all kids, 0 to 18, so we don't have, it's difficult to break down for this 0 to 5 population. This is all kids.
Okay, and how many kids do you think there are under 18 in Scott County again?
About 10,000.
For 0 to 5, there's about 10,000, or
Yeah.
0 to 4 for
Oh,
all.
40?
kids,
I'm talking
there's
to
about-
18.
Oh, 40,000.
40,000? Okay.
The 5-year average for 0 to 219, so including 18-year-olds, is 43,516.
Thank you. Okay, so then just in the simplest terms, because I know this is really complicated data. So for on page 16, so there's a small percentage of kids who, between 0 and 18, there's a small percentage of kids who our assessments would indicate have experienced 2 episodes of harm in a year. And so that is still something that we would look at, right? Like, we would be worried about that.
Right, I think the next step is, do we need to drill into then who is part of that?
Okay.
How does that perhaps look at our 0 to 5 population? Again, that's hard data to get to, and so it would be really just continued conversations with the department about what we can extract from their system.
Okay, thank you. Okay.
The goal really for slide 16 is really 0, right? We don't want kids to have repeat situations that occur.
Okay, what are we doing for time here? Can I just ask, like, as you have learned things working with the 0 to 5 group, what is the mechanism for sharing what you're learning with the other public health nurses and other teachers and other child protection workers? Like, how is the broader system benefiting from this work?
Chris, can I add to that? I had a question here. I was out on a visit with Terry for public health, and I found it absolutely fascinating. And her connection came from mental health, if I remember right, and the mother and dealing with that. And so again, could you talk a little bit about how that connection came? It was amazing to me that this upfront investment, I think, is going to pay huge dividends down the road. And watching that little guy and playing trains with him, and the relationship the mom had with Terry and knowing when to use the crisis nursery, the physical health her father went through. He is on track, this at-risk kid, to be ready for kindergarten. It was just an amazing experience to watch, and I think it's exactly what you're trying to get at, and that coordination came early on between departments, I believe, in HHS, and so I think that's part of what you were getting at, that coordination. It's what we're looking for, and so if you could talk a little bit about that as well, I think it would be great.
Yeah. Terry's here to speak specifically. Is there anything you want to add specific to that situation and how mental health or
mental health provided a referral to public health for home visiting services for prenatal mom.
They can't hear that.
So
The Scott County Mental Health Services Department provided a referral to Scott County Public Health for home visiting services for this mom prenatally. And so we were able to meet prenatally, which we know. Do I need to repeat again? No, okay. We were able to meet prenatally so we can establish a relationship and start the work that we need to do. But it came from Scott County Mental Health. And then I was able to work with Scott County Mental Health and team so that we could provide services that best met this mom's need.
That's pretty typically the model, and we've been doing some internal work on how do we identify those families early and offer them those things. But as far as our programs and services go, we're just trying to make sure it's accessible for community partners to refer in and out, because we connect just as much with others there. But those are the things Suzanne mentioned about when we know a mom is using in pregnancy, how can we jointly approach and offer her some supportive services to help get her treatment ready or get those resources in place and other things she needs, other stressors that are contributing, and supporting that parent-child relationship along the way, so that child can stay on track. Things like the referrals when a family's screened out, how can we offer to them early?
The data Terry had, even following the crisis that was going on a couple times in the family, and the weight of the child, and how closely you monitor that and can see it. And the visit was just about as much about the mom as the young boy. And as I was playing with him, watching Terry work with her, so to Suzanne's point, it was the whole family. It was both of them were needing to be working together, as well as the father. But that relationship that was built, the trust that was there, was just amazing between both of them and Terry, and what that would do to get him ready for school and provide her stability. It really was. And just how that coordination came from mental health, and what you guys are doing there to break down those barriers, every step you're doing, can only help those families moving forward. And it was truly, truly an amazing visit.
I'm so glad you're able to join. Thank you for your perspective on that. I think there's a significant amount of time, not just in public health, but all of that kind of case coordination and case management that's happening is getting releases for the other folks who are involved, and with the family's consent, and being able to talk about this would be helpful, or this is something they need. There's a significant amount of time spent on families' behalf to coordinate those kinds of things. There's a team. Most often that's when we know it goes best, is when there's a team wrapping around this family and everybody doing their part, not duplicative, but in each swim lane to really help support them with what they need.
One of the things from this group, I think that you're speaking to, Leslie, is what you saw, as I understand it, was the power of the relationship with the family and the difference that makes. And then it sort of speaks to like the power of the relationship within this team, this multidisciplinary team that we have formed, and just the relationships that are renewed or newly developed. And I don't know how we measure or capture that and the impact that it makes on our work, but it feels very powerful to me every time we come together.
And to Sally's, I think it's Sally's point was that trust is built then going down the road as well. They're more apt to talk and utilize help when it's there to make sure they're successful. It only has to help build that trust. I mean, that's been a big point from Live, Learn, Earn through this whole thing with the school district and Shakopee Schools, is how do we build that relationship to help that support. So you can see some of it starting to break down in your efforts moving forward. It really was a really good visit.
Are there barriers at the public policy level across disciplines that others can help you break down, that you've identified? I know you've talked about some with the data sharing, but are there other things that others could help break down to enable your work?
It takes time and intentionality to do, the partnering, the collaborative work, the mining of the data, in addition to kind of the programs and services that we're needing to do. So I think we do the best we can and move it forward, but there's so much more we could do if, we work within our capacity or within the time that we have to do it, as important as it is. So
I think, Laura, you hit on already, data sharing is, and so what happens at a state policy level around the ability for internal and external people to be able to share case level data. I think even sustainability, I think that has to be on the table. Mary Kay and Julie really took this on to help co-facilitate this group. But by and large, Heather Wilson, our Foster America Fellow, is helping to support that. And they're doing that in the midst of really already full-time work. And so I think how we continue to carve out and think about sustainability is just a challenge. And certainly then drilling back to a frontline capacity, staff are busy every day. And so how do we help continue to support them to have the space in order to do the consultations and things to support it? Because we know that outcomes are better, but the capacity to continue to invest, whether it's internal staff or external partners, is just always a challenge.
I wonder if we could open it up for audience questions at this point.
I'm loud. I have a question on page 6. You talk about a new partnership with St. David's. I'm kind of curious what you see as that partnership. What's that going to bring to the table? How will that benefit that work? And then kind of just a secondary question, are there other pieces missing, or are there other services that could help support the work that you've identified?
So St. David's partnership is a result of a grant through the Sauer Family Foundation. And it's really looking at 2 interventions geared towards children 0 to 5. ABC, or Attachment Biobehavioral Catch-Up, ABC because it's much shorter to say, is an evidence-based program that we are really piloting to look at a placement prevention. So again, evidence-based, and do we have opportunity as we pilot in connection with, in partnership with St. David's, do we see that we're better able to maintain children in their home with parents who are struggling with substance through the use of ABC? And so that service is just getting underway now. It will be for small numbers, but it's a 2-year grant where we will track that data and talk about, is that something we can build up and scale up based on outcomes? The other service as part of that pilot is fostering relationships, and that really is shifting the paradigm of supervised visits. And so it's moving away from an agency representative supervising visits and training foster parents in some attachment work, and then partnering with parents for visitation. So we're even trying to, how do we redefine, instead of saying supervised visitation, what else are we going to call that? But it's around, does that support parents and birth parents coming together quicker or faster, which will then support reunification, hopefully quicker, and support that that's long-term safety for kids moving forward. So that service we're hoping to go live here probably in September. So depending upon outcomes of that, it would be, do we scale that up in some way, in a broader way than what we have right now? I forgot your second half of your question.
Anything else we're
missing?
I think one thing that we talked about is just expanding the number of outside agencies into our group, because I think we've all seen such a benefit to the community, but also our individual programs, to have more people at the table.
I think other gaps that we have heard, and again, in different places, Pam, so not solely the Birth to 5, but some of the community advisory work around the steering committee to end child abuse. We heard certainly mentor services, both mentor services for kids, mentor services for parents as a gap. Sort of how do we mobilize both formal mental health, chemical health services. Julie referenced I think Samantha here, one of our Birth to 5, talks about when you have a parent who's saying, I'm on the phone, I'm ready for treatment, and we don't have a place to go for treatment, how do we help build that up and scale that up? There are new federally approved services around parents and children being together in a chemical health treatment, but accessibility of those services are really limited across the state. So again, how do we, as part of a state and county, help to mobilize some of that? And then building up, how do we build up a broader sense of community so that there are informal supports to help keep families out of involuntary service? I have ideas around, again, are there different ways, this is this longer term work of, sometimes I think providers feel like the only way to get the family service is by calling into child protection. Is there a different way to look at family service hubs or something that create a place for calls to go into that can provide supports to family that doesn't result in a family coming in through child protection? And that will likely require policy and legislative action, but those are longer-term visions.
That's definitely one of the gaps you listed, and if all those small group meetings that I've held, if there's one thing I've heard from HHS staff over and over again, it's the lack of nonprofits and those type of community supports. Yeah, housing was one of them, I remember specifically back there. How do we prioritize those as we start to approach 200,000 people? I think those types of things are going to be needed more in those community, and in this community, how do we actively work for and prioritize what those needs are and try to bring those into our community? Are you guys looking at that or looking at what those priorities would be as we start to talk about it?
I think that's ongoing work, and so when we hear mentoring services, it's like who do we know that's out in, perhaps outside of Scott County, but who do we have relationships with, or who do we help build relationships with, and then talk about what would it take to move into Scott County. And so certainly we're in conversations around a mentoring group that would work specifically with kids in foster care. So that's one. There's Treehouse, which is another nonprofit, not specific to children 0 to 5, but on the other end, it's really looking at our adolescents. What would that take for them to establish a presence? So I think it is prioritizing based on what we have heard either internally or from community, and then looking at what it would take, and certainly funding being a part of that conversation.
Minnesota historically has had some concern about how people of color are treated in terms of the experience and the success of outcomes. I hear that building the data and being comfortable with the data is extremely challenging. Do any of the members of the panel have kind of some sense about how distinct the treatments or the outcomes are for people of color or tribal members or other groups that are subcultures compared to whites?
Yeah, I think that's a really great question and observation. I can say that as a state, Minnesota, from a child welfare perspective, has some of the worst outcomes in the nation regarding children and families of color and American Indian. And so when we know they are overrepresented in reports that come into the agency, they're overrepresented in child protection responses, they're overrepresented in placement. And so I don't know the exact solutions, but it is a part of conversations, and that's why certainly Nancy and I have worked together for a long time, and it is how do we continue to build relationships and think about an equity lens, like we have ideas, but I'm not a person of color, and so how do we look at engaging different populations to make sure that our ideas are in fact ideas that may be helpful and supported to those particular communities. Because we don't want to reinvent, we come up with ideas and solutions for a population and just reinvent the cycle.
And I think it's been helpful for my staff to come over and do staffings. Every morning there are cases or staff that have come in. And when I've had staff do that, that's been a really positive experience because we're sharing our ideas and different perspectives at looking at the family dynamic or any other aspect of, like for myself, the Native American culture. So we find that really valuable to join and to be able to share those things. So the more we do that, the more comfortable we get, I think the better outcomes we have.
A second question, historically for the last 35 or 40 years, there has been kind of more comfort level in Minnesota with non-mental health coverage, so doctors and hospitals get funding. As you have conversations and work on kind of where you want to go with this group, are you getting the sense that, like from the state or from other funding areas, that there is a possibility of getting additional funding, or what might be considered adequate funding for some of these initiatives and ideas?
I think there's always, there are funding opportunities that we can look at. Like, we don't know what those will be until they begin to surface, but I think there is increased momentum from a state of both looking at evidence-based services, because it's part of federal legislation that we will have to implement in the next 2 years. And I think there's an increased awareness around the prevalence of child protection or child abuse and neglect and placements. And so how do we look at services and resources that are multi-generational approach? So again, we didn't get this 2-generation grant, but I anticipate that there will be other opportunities for us to explore. And then there is the piece of the capacity to organize that and then figure out how best to use the funds. So I think there are opportunities, certainly.
If I can add from a health perspective, at a federal and a state level, there's a lot of attention and energy and funds flowing around early childhood, particularly evidence-based home visiting programs. One component of that comes from the federal level is we need to be working to we're accountable really for creating coordinated early childhood systems. So as funds are coming down, it's not just building in silos, it's how are we using those funds efficiently and effectively and coordinating. I think it's a nice model of what we're doing here already to do that.
I think there will also be funds to support evaluation of interventions because they need to be looked at as evidence-based. But we know a lot of existing evidence-based services aren't in fact evidence-based for kids of color or American Indian families. And so how do we potentially look at intervention strategies and then look at evaluation to help build evidence to support those programming?
And I think within the realm of housing, we'll see increasing effort given towards identifying opportunities for expanding family supportive housing opportunities across the state. And so we'll look for ways to better ensure that we're integrating services within a residential setting.
Do we have a last audience question?
I have a mic.
Oh, you do have a mic.
I was just going to comment that we've been working on getting legislation passed that would allow more data sharing. But in light of the fact that that hasn't really happened yet, Dakota County has gotten a pilot project and we're hoping to build off of that at least, but it still requires parental consent. How does it work if you refer families? Would it be significantly more effective if you could give the name to somebody who could contact the family instead of the other way around, giving the contact to the family? Is there follow through? Is that a huge problem? What happens when you're trying to connect them to another service?
Well, I can speak for in child protection, I mean, almost all the time, if we can actually provide the information and have somebody reach out to the family, I mean, I think that is more successful. When we can't do that, sometimes we sit with the family and we make the call with them to try to help make sure that the family is linked to the service. Not to say that some families can't, and like many families will do it on their own, but when possible, we try to make sure they're linked.
I can also speak to that from the consultation that I had. Park Nicollet had me de-identify substantial amounts of information to be able to do a case consultation, and while it was beneficial, it would have been more beneficial to be able to share some of that identifiable information. The consultation, I think the data privacy piece was impactful in the consultation that I did, just because I couldn't answer specific questions that some of the group was wondering about. And to be able to have that freedom to be able to answer some of those questions more readily would have helped me and also helped the group provide better feedback for me.
All right, Madam Chair.
Thank you. Thank you to everybody. Questions and comments from the board? Commissioner Ulrich.
Yeah, I was just thinking that it would be helpful for me to see what a healthy child looks like in terms of the different, before they're born, up to 6 months, or just the different ages. If you were to take a step back and not think of your departments, but have brainstorm as a group, what goes into a healthy child? What is a healthy child? What do they look like? What do they need? And then where are the gaps? What are we doing well? What are we not doing well? I mean, for example, library's not on your team, and we have kids that can't read at third grade, and we have a problem with reading. So if you said a healthy child is reading ready, you'd have the library on your team, you know. And so I think if you could take a more comprehensive step back, I mean, a healthy child is not homeless. How many homeless families are there in Scott County? Where do they go if they become homeless? I don't see data there. I mean, you know, so I think there's a lot of good work here, a lot of things happening, but a lot of things are missing from what is a healthy child, or, you know, what goes into making a healthy child, a healthy family. I'd like to hear more from community education. I'd like to hear, like if Sally's working with other school districts. I'm on their site with the building blocks of learning, and it looks excellent. But I went to another school district, and I couldn't find anything like this. We encourage conversations with all our partners in Scott County to work together, and I'm just wondering, is that happening, you know? And so those are questions I have. You know, it would be really helpful as a policymaker to have the information. And we've got big gaps here in this part of a healthy child, homelessness, for example. How do we deal with that? Or reading readiness, or whatever it is. So, but it's good work here, but I'd like to see more.
Thank you.
I bet you could give us more if we had 3 more hours.
Yes.
Commissioner Beard.
Thank you, Madam Chair. Just 2 things. One, I serve on the CAP agency board, and I know they deal with early childhood, and I heard early childhood development spoken about here this morning, but my question is, do we coordinate with or cooperate with the CAP agency on the early childhood stuff as well? Or how do they fit into this picture briefly?
As a representative from the CAP agency, I work closely with our Head
There
Start
you are, right
department.
Never mind. I missed that in the introduction. Down the road, thinking, oh, there's CAP agency. You're right there. I can see it. Thank you.
Yes.
And from a housing perspective, we work very closely both on prevention and homeless dedicated services. To speak to the point you brought up earlier, currently via our coordinated entry system, which if we harken back to February, you'll remember everything that you learned about coordinated entry. We currently have 24 families identified Scott County as their county of primary residence who are experiencing homelessness and are awaiting a homeless dedicated housing referral. Of those, they're averaging about 411 days between point of assessment and referral.
Madam Chair, just one last housekeeping item for Chris. I appreciate that some time ago somebody took my suggestion, we put page numbers on everything so we can find them easily. Another suggestion would be, I serve on a healthcare board, and I'm not a healthcare guy. What I find most helpful in every packet is just inside the agenda page, there's like 4 pages of acronyms and what they mean. There were a lot of acronyms thrown at us today. In fact, I'm looking here on page 5 and I see PUP and PH and MDT, and they just go on and on, ABC. If there's a way they can be, sometimes we just get a little cheat sheet.
We can
We use other acronyms to describe them.
Oh, you do?
Good suggestion.
Thanks, Commissioner.
Thank you, Madam Chair. Thank you, Chris.
Comments, questions?
Yeah, thank you.
Commissioner Beard.
So, you know, we see this topic come up, and, you know, we talk about it on a somewhat regular basis. And I always hope we're talking about widget production. You know, how do we move from 90 to 95 widgets per hour? But we don't. We're talking about souls, the human condition. And you guys are in the soup. So I think I probably ask this question every time this comes up, but how do you guys guard your hearts in this process? Time and time again.
I think it's, from a child welfare, Commissioner Beer, I can say it is a particularly, it is near and dear to me of how we are as an organization supporting our staff. By history, we have had a strong workforce, and we still do, but we have by history not have had turnover, and we are experiencing significant turnover in our protection. And so it is an urgent concern of how are we pacing the work? How are we helping support the development of new staff? And taking care of each other in that process. And so I think it is an ongoing conversation of how do we, from a management, how do we support frontline staff, how do frontline staff support each other in that work? But it is an ongoing conversation because I think certainly the idea of what you're referencing is really secondary trauma. And so what are the supports that are needed individually, organizationally, to support staff in doing what is really just important work. We have a history of long-term good outcomes, and it is really the reflection of the work many of these people do and the frontline staff that are here.
Well, I've got a follow-up question, and I'm going to ask this question in an abundance of clarity. I am in no way implying this happens. So but I want to ask the question because partly it's got to be a calling. Just my opinion, it's got to be to do this kind of work. But when you're in the soup all the time, how do you make sure that you and your group and everyone involved is doing the right thing versus sometimes the easy thing? And again, I'm not implying, I don't want anyone to hear like, oh my goodness, but the human nature of it, like, oh, it's heavy. It's a heavy, heavy lift.
Well, I can speak to that. When we do our case consultations with the B25 group, that really gives us an opportunity to talk about our struggles and what we're doing, and just to get the feedback from everybody so we know, are we on the right track here? Are we really skewed with our thoughts? Even though we think we've looked at it from every angle, the experiences that I get, I always come away with something new and valuable. And it really kind of gives us a good boost to all of a sudden that team around us is a lot bigger and there's a lot more support and we all feel it. It's a real powerful thing.
Power of community.
Yes.
Strength in community.
Well, I think Commissioner Beer, if I can add to that, as a child welfare, we really use signs of safety, which is our practice framework, and that is very much grounded in team decision making, that no one person has to shoulder the weight of decision, that they don't have to be out there alone. And so some might say, well, are you supporting independent thinking? And we certainly do, but it is very much around how are we caring for and supporting people who are making really life and death decisions every day. And it is about a team, a structured sort of team decision making.
It's awesome. One slight little, I'm going to take it heavy, but Melissa, you had mentioned early on that dads were more involved in this, what was it, the parents of parents?
Parents helping parents, yes.
And I don't know if it was the same group or another group, but similar topic where one of the issues was trying to get dads to the table, trying to get dads involved. So what's the secret sauce in that group to try to get dads more involved in the process? If you've got
That's a
if
great
you've got the
question.
silver bullet, we'd love to hear it.
Yes. It's something that I've worked hard with Crisis Nursery to be able to identify the father in the home. Oftentimes when we go out on a home visit, they're not there or they're hiding in the bedroom. And so I think that it's really the relationship piece and really trying to engage both parents in the development of the child. And I think a lot of that comes through that soft referral process that we've used in our B25 group and throughout this collaboration to really engage the dads and empower them to know that they're just as responsible and capable of producing a well-rounded child as the mother. And I think that it's kind of a paradigm shift. Dads are getting a lot more involved in the raising of the children in the home as moms are more in the workforce and things like that. So I wouldn't say that it's all based on our secret sauce. I think it's a shift, but we really do try to work hard to engage dads, but I think that we can all do a lot more, and I'd love to see more within the county around programming specific to dads and things of that nature.
Love it. Also love the piece of mentorship. I'll just leave it at that.
Thank you. Commissioner Wolf, any comments or
I guess I would
questions?
just make a comment story Saturday night, which makes it timely. There was a woman at a get-together, and she had this little 6-month-old baby, and my wife and I were like, oh, we didn't even know. But it wasn't hers. It was she was a foster parent, and the mother of that baby was on drugs and stuff, so they had to give the baby, give it to this woman, she's a foster care person, and the 6-month-old, perfect baby, and so the baby's gonna get adopted by the mother's aunt, so that the baby can stay, but, the baby was in such great shape, and I said to the woman who, was the foster woman, I said, well, so what happens, you've had this child for 6 months? She said, that's the toughest part, is, the day we someone comes and says, the adoption is final, so that kid may, probably never, have been raised for 6 or 8 or whatever, just all of a sudden gone, and the kid may never know that person again, so it's real life stuff, so that's
Yeah, certainly we see, the goal is how are we keeping
Yes.
kids connected to relatives. I think certainly that the foster parents who step forward, we ask them to do really the unimaginable. Love kids, love their families, enough to let them go, whether it's home or with another relative. But how we plan for that and how do we transition, like how do we keep child development in our eyes around what do we know 6-month-old babies need? So how do we work with both the current provider and the adoptive parent to support that transition, but certainly hard
And
scenarios.
tougher, she said, she's been a foster, but she said some are much tougher to let go than others, so you know that, I'm sure, so, thank you.
Thank you. Thank you for your comments. I just will summarize, sum it up a little bit. Of course, I have all kinds of notes and lots of questions, and Suzanne already knows it. She'll be happy to get an email from me with all of them. I've learned to only send them to 1 or 2 people, and then they can pass them on if they want. Most of all, though, on behalf of the board, I want to say thank you. This is such hard work, such important work. And I just want to talk about the context a little bit. Those in the room, everybody here is so supportive, but for the greater audience, I think sometimes people look at this newer work that we're doing, this teamwork, and think, why is the county doing that? Isn't the county's role just to protect those kids that are getting beaten and abused, neglected? Stay in your role. Well, I think this is just demonstrative of what we're trying to do. We're trying to save lives. And if that's not enough, if there's some people in there who that's just not enough to save lives, we spend $2 million of levy on these programs. We spend $5 million of tax dollars on these programs in Scott County. That money could do so much more good if we could solve these problems, if we could get upstream. So I thank you. You are my heroes. I am going to especially call out Nancy, Alyssa, Sally, and Melissa today, and thank you for being part of this team. I hope you continue to not only contribute, but help hold us, and I hope our staff will hold us accountable for the county's role here, for what we can do better, what we can do differently. I just think that's what's really amazing. That's what's really going to change things, because I think as Heather Wilson and our goal of ending child abuse and neglect in Scott County, as she keeps telling us, our role, yes, is just to step in those dire circumstances, but it's really our whole community's role to change the narrative, to change this. And so help us recruit others, help us broaden this, so if we have ECFE folks in Belle Plaine or clinic providers in New Prague, that they feel like they can access this group and access this wealth of information, this better way of doing business. I'm passionate about this, and I can't wait to hear where we're at in 2 more years. The change in the last 2 years has been amazing and really good. So thank you for your time and effort and all this work.
Thank you.
All right, we will not recess.